I'm Andy Orm from O'Reilly. I'm talking to Tony McCormick, who is a longtime advocate of open healthcare, and he's doing technical support for ACOs, which we'll talk about in Houston. All right? So tell me a little bit about an accountable care organization.
So the Accountable Care Organization is a program that came out of the Obama Health Care Act and is a way of managing Medicare and Medicaid beneficiaries that's sort of a halfway step between an open network and the HMOs that they currently use for Medicare Advantage. So it's meant to cut the costs of Medicare in the long term and provide improved health benefits as the backside of that project.
It's really hospitals and the doctors who work with them looking at the whole situation, and they're trying to collect statistics about everything they do and figure out how to make it more efficient. Is that right?
Yeah, that's basically it. It's mostly about the communication of the data and the coordinated care of the patient. The accountable part of it is making both the patient and the providers accountable for the care of the Medicare patients rather than just leaving it up to random guess.
So now that you're putting all these people together, what are the challenges as a technical support person?
Well, the biggest challenge right now is that the data communication models aren't solidified yet. There's a lot of different kinds of medical practice management systems and electronic health record systems that are in these provider offices and in the hospitals that are not the same and aren't up to the current proposed standards for data communication. So they're expecting basically for an accountable care organization to be able to hit the ground running and collect this data and manage the care without any real connections yet to do it. So there's going to be a lot of interim data manipulation management techniques that are going to have to be deployed in order to at least get through the gaps until we get to a point where we have a standard.
You're trying to get system A to talk to B and B and C to talk, and you've got as many translations as you've got systems?
Yeah. Just as an example to start with, the CMS itself for ACOs only, uses an XML format for exchanging minimalistic patient demographics and preferences. Well, that format is well and good and at least reasonably easy to use, but it's not a standard data dictionary kind of format, and getting information from the providers from their systems isn't going to come in that format. So,
and furthermore, aren't ACOs supposed to exchange a lot more information than the old-fashioned continuity of care document?
Yes, quite a bit more, in fact. They want you to be responsible for the entire life cycle of a patient's care, and in this case, that is pretty heavy as you're dealing with an elderly population who has high morbidity rates. So there's an enormous amount of data involved in that needs to be collected both from the providers who are seeing the individuals and from the various entities that they end up touching, either it's specialists or it's hospital data or hospitalization data. And then there are also social worker type involvement as well for home health care purposes. And so there's data that's collected in the field that has to be disseminated back into the network.
Are you creating a new format, or are there formats out there you can use?
Well, we have to do some of both. There are formats out there that are recommended, and there are formats that have been in use in the healthcare industry for a while, such as HL7 and X12 for some of the claims data and results data. But there's no real standard yet, and a lot of the formats like CCR, CCD, which are the continuity of care records and the continuity, I'm not sure what the CCD even stands for anymore. It's changing, but that in 2014, even that changes. So they're merging those two into somewhat of a new format. So it's a rolling target right now to try and keep up with the format. So there's a lot of technical work that needs to be done in terms of making sure that whatever tools you're using to take in the data and to disseminate the data back out are flexible enough to sort of roll with the times. You add the complication of every one of the providers having a different system, and that even though they're all targeted, if they're certified EHRs, to support a certain number of those standard data formats, we're far away from them being deployed everywhere yet. Even if they're headed there, they're not there yet. And so there's quite a lot of entities in the market that are either don't have an EHR at all, or they have one that they're in the process of deploying that's not compliant yet, potentially. So there's a whole lot more of those than there are compliant EHRs that have even the CCR level standard, which is pretty minimalistic.
So instead of going on for a couple hours, which I could do about the formats and the direct project, all kinds of stuff, let's turn to, suppose you did get the data back and forth. What kind of data crunching would you like to do? What information would you like to get?
Well, the challenge with this is that there are two kinds of data. We have data that needs to come in that is essentially evaluation data. What is the evaluated state of health for a given entity? And that can be pre-diagnostic in the sense that you could have somebody who appears in a patient's home and is reporting data like, they really could use some help just keeping their house clean enough to stay healthy. And there's no diagnosis code for that. Right? So some of this data is going to come across that's uncoded data that needs to be parsed in ways that can trigger actions as a result of it, so they can order social services to come in and help out. There's a lot of non-governmental organizations, as they say in the third world, that go out and help take care of people if they can be told. And some of those are supported by the Medicare and Medicaid programs. And so if you can get out of the front end the kinds of health information that are going to affect an elderly person's health long term, and you can get that and cause it to trigger actions that result in people finding out that what they really need is the local food delivery person to show up on a regular basis and bring them food because they're hurting in terms of just getting food to eat, then that's going to reduce the morbidities and it's going to reduce the cost of healthcare down the pipe. On the flip side, if they do end up in a hospital situation, then you need to get the information on their care, and you need to get it right away, because what happens in these hospital situations is that the hospitals will tend to treat, they're paid on treating what's called diagnosis-related groups. And so they will treat a patient on the basis of what they were diagnosed for, and that's how they get paid by Medicare. All right? So as soon as that activity is complete, there is a possibility that person will be discharged, even though they're not healthy enough to be discharged yet, because they've already sort of used up their ticket for a particular diagnosis group, and so it causes readmissions into the hospital. And so you need to make sure that you have hospitalists in place who can monitor the actual care in the hospital itself and report on it almost real time, so that you can manage that. If you don't do that in the format of an ACO, then you won't be able to reduce the cost of Medicare and the cost of the business in the end, and you won't, as a business, you don't get to share in the shared savings. So the whole purpose of an ACO, in terms of the business aspect of it, they make their money by sharing in the savings that they help generate for Medicare by managing the care. And so if you can't get the data in advance and a really timely basis, then you can't manage the care, and the ACO will essentially fail for lack of income.
You can be penny wise and pound foolish,
Exactly.
and discharge a patient or not follow up on a patient, and then you end up the patient costs you more
Right.
in the long run. So
And in the Medicare Advantage programs, that's manifest very quickly by people showing up in the emergency room. They didn't get the care. They could have gone and got their diabetes under control, if they were seeing their PCP. If somebody had known that they had diabetes and that could and inform them educationally how to get there, but they end up in the emergency room, and the cost to Medicare and to the taxpayer, it ends up being enormous because there was no front end preventive care going on. And you can only do that by getting the data, and you can only get the data by sending people out in the field and then bringing it back in and analyzing it.
So there'll be will there be technical people out in the field, not just the social agencies, but staff from the hospital going out to the patient?
Not particularly. It's mostly it's the social agencies, and then typically nurses or nurse practitioners who are capable of doing some diagnostic work. they can collect the data and do preliminary diagnostic work and get it back. What we have to do in the field is provide tools to allow them to do that easily and to do it safely and encrypted, so that we're not dealing with HIPAA violations that result in important and private medical data leaking out into the world because a laptop was stolen in a poor neighborhood or even a rich neighborhood. So we have a lot of software that we've developed for this and will continue to evolve that makes it easy to collect medical data in the field and to do basically this sort of mini EHR in the field, but keep it really tightly encrypted and safe so that the loss of that data is not part of the problem.
I think you're really on the forefront, Tony. I'm hoping that a lot of other organizations around the country can learn from what you're doing, and I'll continue to talk to you and keep people informed about what you're doing.
Thank you very much. Pleasure talking to you.